For decades, standard medical practice operated under a staggering biological assumption. Up until the late 1980s, the prevailing medical consensus was that an immature, underdeveloped central nervous system protected premature infants from experiencing pain. Because a neonate is unable to definitively express pain, clinicians concluded that pain was neither perceived nor experienced. This led to a routine clinical consequence. Premature infants regularly underwent major tissue-damaging procedures such as chest incisions and ductus ligations without any anesthesia or analgesia. This clinical standard collapsed in 1987. Prompted by severe public outcry, the American Academy of Pediatrics issued its first official recommendation for newborn anesthesia. This policy shift was quickly followed by a comprehensive physiological review of neonatal stress responses by researchers Anand and Hickey. Their work revealed a neurophysiological state completely opposed to the old consensus.
The neonatal brain is actively biased toward extreme excitation. Sensory cutaneous receptors and ascending neural pathways are fully synapsed and capable of transmitting nociceptive signals to the sensory cortex by just 24 weeks of gestation. By misunderstanding the timeline of developmental neurobiology, early clinicians missed the reality of neonatal hyperalgesia and high susceptibility to unmodulated seizures. In the modern neonatal intensive care unit, this excitation bias manifests in two primary ways: severe hyperalgesia within peripheral pain pathways and highly synchronized electrographic seizures in the cerebral cortex. The cellular mechanisms mediating these pathways do not operate like a mature brain. In several critical instances, they function in exact reverse. Because of this inverted receptor physiology, standard dose reduction pharmacology fails. Treating neonates as scaled-down adults and simply prescribing smaller doses of standard medications ignores the actual mechanics of their nervous system. To safely administer neuropharmacology in the ICU, practitioners must abandon mature clinical models and directly map the unique cellular structures causing this intrinsic excitability. A standard pain response requires 3 biological steps: transduction of a noxious stimulus at the site of injury, transmission of that signal to the brain, and modulation of that signal by the nervous system. When an infant experiences a tissue-breaking procedure like a heel stick, action potentials propagate from peripheral unmyelinated axons directly to the dorsal horn of the spinal cord. While incomplete myelination in a premature infant slows the physical conduction speed of this impulse, it does not prevent the nociceptive signal from reaching the thalamus and projecting into the sensory cortex. The structural deficit in a premature infant lies in modulation. The descending inhibitory pathways, which originate in the brainstem and travel back down the spine, do not mature until after birth. Without these descending tracks, the infant's body cannot release the endogenous endorphins required to block or dampen incoming pain stimuli at the level of the dorsal horn. This creates a clinical state known as hyperalgesia. The pain is fully perceived by the cortex, but it is physiologically impossible for the infant's own nervous system to modulate the sensation. Subjecting a developing nervous system to repeated pain exposure in this unmodulated state leads to the wind-up phenomenon, permanently lowering the infant's pain threshold. Therefore, the severe agitation observed in the NICU is a direct response to chronic nociceptive bombardment, unmodulated by standard internal pathways. This extreme excitability also extends deep into the cerebral cortex. Neonatal seizures occur in up to 3.5 per 1,000 term births, making the first month of life the highest risk period for seizure activity in human life. The vast majority of these seizures are acute, symptomatic events, triggered by severe brain injuries, specifically hypoxic ischemic encephalopathy, or intracranial hemorrhage. To stop these seizures, neurologists target gamma-aminobutyric acid, or GABA. In a mature central nervous system, GABA is the primary inhibitory neurotransmitter. This diagram illustrates how the mature receptor works. When GABA binds to the GABA-A receptor in an adult, it opens a channel that allows negatively charged extracellular chloride to rush in, hyperpolarizing the membrane and silencing the cell's electrical activity. But look at the neonatal neuron membrane on the right. In the developing brain, neurons heavily express a specific cotransporter called NKCC1.
NKCC1 actively pumps chloride into the cell. Meanwhile, the expression of KCC2, the transporter responsible for exporting chloride, is severely delayed in neonates. This imbalance creates a state of severe intracellular hyperchloremia. The neonatal neuronal membrane is packed with negatively charged chloride ions. As a result, when GABA binds to the neonatal receptor and opens the channel, chloride actually flows out of the cell, moving down its artificial concentration gradient. This massive chloride efflux rapidly depolarizes the neuronal membrane, driving it closer to the threshold of an action potential instead of inhibiting it. When an acute brain injury releases a surge of excitatory glutamate, this paradoxical GABA activity fails to provide the necessary braking mechanism. Instead, it creates a cortical environment perfectly primed for synchronized electrographic seizures. Administering drugs into this inverted physiological state is incredibly difficult. Practitioners must constantly adjust doses to account for highly dynamic, gestational age-dependent pharmacokinetic parameters. For example, a premature neonate has a high fluid volume and a very low fat-to-muscle ratio. This radically expands the volume of distribution for highly lipophilic analgesics like fentanyl, requiring carefully calculated dosing to achieve efficacy without causing drug accumulation. Furthermore, premature infants have significantly lower serum albumin concentrations. This reduced protein binding drastically increases the active, toxic, free fraction of drugs like sodium channel blockers circulating in the bloodstream. This graph charts phenytoin clearance, providing a prime example of dangerous, nonlinear elimination kinetics in the NICU. Phenytoin is metabolized primarily through hepatic oxidation by the CYP2C9 enzyme. In an immature liver, this metabolic pathway becomes easily saturated. Once that saturation point is reached, clearance decreases and the drug accumulates exponentially. The therapeutic margin vanishes, risking rapid and severe toxicity. These metabolic pathways are further altered when an infant undergoes therapeutic hypothermia to treat hypoxic brain injuries, which induces a severe systemic and metabolic slowdown. The combination of these shifting physiological variables, maturing liver enzymes, and hypothermic treatments makes achieving a safe, steady-state therapeutic concentration a constantly moving target. Ultimately, practitioners in the NICU are caught in a clinical double bind. They must balance the destructive nature of the underlying pathology against the severe neurotoxicity of the cure. Leaving pain and seizure burden untreated guarantees long-term functional deficits, causing altered synaptogenesis and permanently decreasing overall brain volume. However, the standard pharmacologic interventions used to treat these conditions, specifically opioids and barbiturates, carry their own severe risk. They induce dose-dependent neuronal apoptosis, triggering cell death in the very tissue they are trying to protect. A modern attempt to solve this double bind was the NEO-LEV-2 trial. Researchers tested levetiracetam as a first-line agent, hoping its unique mechanism of bypassing the GABA receptor entirely would avoid neurotoxic apoptosis. This chart displays the trial's seizure cessation rates at 24 hours. The results were stark. Phenobarbital successfully controlled seizures in 80% of patients, compared to a mere 28% for the safer levetiracetam. Because of this profound discrepancy in efficacy, a reluctant clinical standard remains in place. Despite its known apoptotic risks, phenobarbital is still the undisputed first-line therapy for neonatal seizures. Neonatal neuropharmacology is not about achieving a perfect cure without side effects. It is an exercise in highly calculated harm reduction, relying on precise pharmacokinetic monitoring to suppress intrinsic excitation while minimizing the necessary toxic footprint left on the developing brain.